So doing our first question. Oh gosh, okay, here it is. The code, I think, is different. Someone correct me. So as you go into that website, okay, it's veritasars.org. It's also, it'll come up on the next one. There it is. Okay, so the website's right there in the bottom, okay, veritasars.org. The new code is right over here. All right, and while everyone's typing it in, once you've typed it in, you can now read it. And it's a question about penetrating atherosclerotic ulcer. We'll see if we can get our number up to around 25 or 30 as everyone types it in. All right, perfect. Most common, the descending. Perfect. So the only one said easily differentiated. So let's go back to the presentation and we'll talk about that difference. So our answer was descending is the most common. So penetrating atherosclerotic ulcers, most common there. If it is in the ascending or a big symptomatic problem, it will get treated, okay? Now, we did discuss how to tell the difference, right? It's the outside contour changing that makes it a penetrating ulcer. The problem is you can imagine a gray zone, right? We're like, oh, did that change the contour? Not so sure. It can be obvious here, obvious there, and a gray zone in the middle. Not always 100% clear. All right, question 2. This is a crazy case, okay? And this is from one of my colleagues, and I will go over it. So here, we'll take out these crazy pictures, get a sense of what's going on. And we're going to ask questions about these pulmonary opacities that we see off both hyla, okay? Everyone taking it in? Okay, and the question is, the pulmonary part of all our abnormalities, what do you think is causing those radiating opacities out from the hyla? Perfect. So bleeding complications due to a dissection with complications. So we'll go back to the slides. This is a crazy case. So what we saw here, there was a dissection, right? You probably caught that in the aorta. The pulmonary artery was also narrowed. The pulmonary artery also had high density on the edge, and then this radiating out opacity. So basically, this was a dissection that also involved the pulmonary arteries. Now, there is an association with the aorta for that, but I can't actually give you a brilliant mechanism, right? They're obviously not directly connected. Why would it spread? But it can, okay? Or at least they are associated. In this extreme case of a dissection of the pulmonary arteries, it went out peripherally and had some bleeding. All right, question 3. We have a pericardial problem. Which would be the most concerning finding when looking at a pericardial issue? Perfect. So we have 2 options. We have size, right? We actually know the heart chamber sizes can get big for a number of reasons. It's not uncommon. The bigger issue is bowing. And the bowing we are worried about is abnormal bowing from the right into the left. The left should be the high pressure, right? You shouldn't be able to bow over there. But if the right side has so much pressure, that's the problem. Okay, it's an extreme hemodynamic situation. Okay, we can switch back. So that was that answer. Okay. Next one from that group. Which of the following is true regarding the conditions seen in this picture? All right, so again, a descending aortic complication. This is the most common location. We see eccentric high density. This is an intramural hematoma. Okay. So the other ones, it does not always need a repair if it's not terribly symptomatic in the descending. If it is best seen in the CTA, then we showed the worst picture possible. So it's actually showed a non-con pretty well, and the high density is blood, not contrast. All right, perfect. Back to the slides. Next question. This is a case of cardiac MR imaging. So here we have a young man with diabetes, strong history of cardiac disease, actually even has some troponin abnormalities, but the catheter evaluated him. Coronaries are fine, which is good because he's 32. But we have then a cardiac MR follow-up. And with these pictures, what is the most likely diagnosis? All right, viral myocarditis, perfect. Okay, good, easy, then we're fine. So, our STIR, that's the one with some T2 weighting. We saw some increased signal intensity. We saw on the post-contrast, the pissers, what a pisser those were, We had some increased delayed contrast enhancement in the mid-wall patchy, classic for viral infection. Okay? And we went over the findings of be more ischemic, right, subendocardial, and in a vascular distribution. Okay? And we didn't see masses. Next, cardiac. So we have a TEE that led to a patient coming our way. They said, oh, it wasn't the best study, but maybe there's a mass. We're not sure. You figure it out. Okay? So we didn't do the test that they wanted for a good contraindication. So here it is by CT. Check it out. All right. And if you're not catching it, because the questions, there's a couple abnormalities here. But I want you to focus in the apex. Notice particularly in the right picture, some low density there in the apex. Okay? Everyone sees it? So our question then about that is, what is the most likely cause of that abnormality inside the left ventricle? Right? Ooh, thrombus, very good. Tammy, you taught them so well. Look at this. Okay, we'll go back. All right, so we saw thinning, we saw enlargement. This was obviously a prior infarct. Poor contracting is set up for getting a clot forming right there. Okay? Hard to catch these. It's like one of those old boards cases. There was terrible coronary artery disease on the side of the picture too. The myxoma is usually atrium, right? Angiosarc, super rare, probably would be somewhere else. We didn't see big masses. Okay, and then to wrap this up, because I want to make sure we end on time, we'll then do 2 questions from our pulmonary artery talk. First one is this. For PEs, no matter what windows you use, which should be the typical Hounsfield units for a PE? All right, look, also too easy, but highlights, clot density, not mixing too high or something else, all right? And we'll switch back. Which artifact is particularly common in the right upper lobe near the SVC? Right near the SVC is streak artifact. That's actually why now we often will inject saline after contrast to sort of flush it out. All right. So we have ended the whole session only 1 minute late, so that's pretty good.